Good afternoon, my dear friends and my teachers. And I think this one molecule, SGLT2 inhibitors, have made cardiologists and diabetologists come together. And diabetologists all over the world have controlled diabetes efficiently to prolong life. And when you prolong life, a lot of people think we die of cancer, but more than cancer is the deadly disease, cardiac failure, which is much more common in diabetic than in a non-diabetic elderly person. So we will have to now learn more and more things about how to reduce the incidence of cardiac failure, how to reduce the recurrence of hospitalization for cardiac failure, and especially so in diabetic. So today the topic is going to be only around that. Let me go with the first slide. Now all of us know it's a very serious life-threatening disorder. Most of the time it knocks the door in the middle of the night. Patient goes dyspneic, breathless, and questioning. They complain of fatigability. So the forward failure causes fatigability and the backward failure causes dyspnea and pedal edema. And lot of times when we were students, we were told only about congestive cardiac failure because of congestion in the lungs. Now it has been redefined several times again and again, and mostly we talk only about chronic heart failure, acute heart failure. Acute heart failure may be precipitated time and again in a patient with chronic heart failure, and HFrEF and HFpEF and HF with mid-range ejection fraction. What are they? Any person, the common garden variety of congestive cardiac failure is a HFrEF, that is heart failure with reduced ejection fraction, and they have set up a line that is 40% ejection fraction, below that is HFrEF. And more than 50%, if the patient comes with features of cardiac failure, echocardiogram shows an ejection fraction of more than 50%, but the BNP or the NT-proBNP is very highly elevated. You call it as heart failure with preserved ejection fraction. There are people who come with reduced ejection fraction, they may improve, especially like peripartum cardiomyopathy, they may improve from 40%, below 40% to 45%. So anything between the 40 to 50% range of ejection fraction and who is on treatment for cardiac failure, we call them as heart failure with improved ejection fraction or heart failure with mid-range ejection fraction. So these are the varieties of heart failure that we are coming across today. And 1 minute, let me see how to use it. Yeah, damage to cardiac myocytes and extracellular matrix leads to changes in the size, shape and function of the heart. And what happens immediately is neurohormonal overactivation. The sympathetic system gets overactivated, the RAS system gets overactivated. And this leads to vasoconstriction, fibrosis, apoptosis, hypertrophy, cellular and molecular alterations and myotoxicity, leading on to maladaptation and remodeling, which causes the morbidity and mortality with arrhythmias and pump failure. And you get the symptoms of heart failure. Now, when a patient comes with heart failure, there are about this is the Western data, there are about 7 to 8% mortality in the hospital. And if they survive the hospital, they go out and they may get admitted. 25 to 44% of patients are readmitted to hospital within 30 days to 1 year. So today's problem is how to reduce the expense for the government and for the patient. In countries where the patient has to spend, you will have to reduce, because every time he goes into the ICU. Anywhere, whether it is a mediocre city or it's a hi-fi city, the one-day ICU charge is so high, it is better to prevent cardiac failure or to treat it better so that they do not come with hospitalization for heart failure again and again. And the patients who have survived the first incidence of cardiac failure, 7% of patients receiving guideline-mediated therapy died due to sudden cardiac death. And the mortality is about 50% in 5 years' time. So it's a deadly disease, much deadlier than cancer. And this is like frequent flyer. Many patients come out of hospital just to get readmitted. So we have to effectively prevent. for which we should understand the pathophysiology. Based on the pathophysiology, all these years we have been having treatment. As we have told in the previous slide, there is an overactivity of the sympathetic nervous system. When we were students, we were told if you write a beta blocker for a cardiac failure patients, we are failed. Today, if you do not write a beta blocker, again we are failed. The reason is very simple. The pathophysiology is very much understood. Because of the overactivity of the sympathetic nervous system, there is tachycardia, and when there is tachycardia, there is myocardial oxygen demand is increased, and there is further worsening of the failure. So to improve that, we had found out a beta blocker as a group of drugs which can reduce the overactive sympathetic nervous system. The RAS, renin-angiotensin-aldosterone system, gets overactivated and retains sodium and water, and therefore worsens cardiac failure. So we have started using from 1990s ACE inhibitors, and recently for the past 20 years ARBs. And an improvement over this is a combination of an ARB with what is called a positive system. These are almost negative system, even though they are compensatory systems. This is a positive system which produces against vasoconstriction. This produces vasodilatation, and therefore it improves the quality of life in a patient with cardiac failure. This also gets activated, but unfortunately this gets very frequently, at a very fast rate, it gets metabolized. The brain natriuretic peptide and the atrial natriuretic peptide, even though they are positive for the patients with cardiac failure, they get metabolized. And why not we inhibit the metabolization of the peptides? And therefore a drug was found called the naprolysin inhibitor, because naprolysin inhibits the naprolysin inhibitor inhibits naprolysin, so that more amount of natriuretic peptides are available in the circulation to improve the cardiac failure. So all these years, till at least 2013-14, we have been using beta blockers, RAS blockers, or ACE inhibitors or ARBs, and in 2010, after the Paradigm HM trial, we have started using ARNI, which is a combination of angiotensin receptor naprolysin inhibitor, and which had reduced the hospitalization for heart failure 17% more than using only an ARB. This is a borrowed slide from GVK, who in 2019 in the same 3D conference spoke, SGLT2 inhibitors, will it find its way in cardiovascular medicine? And he said, let us wait and watch. Now we have waited and watched, and over these 3 years, it has almost become the #1 agent for the treatment of cardiac failure in majority of patients that we see. Now how it has become? Because SGLT2 inhibitors are a unique class of therapies that show beneficial effects across the cardiovascular risk continuum in patients with type 2 diabetes. Starting here, it can reduce the systolic pressure and minimally diastolic pressure. There is body weight reduction, there is HbA1c reduction, there is progression of kidney disease is retarded, 3-point MACE is reduced, that is cardiovascular death, non-fatal MI and non-fatal stroke, and reduction in hospitalization. This is what has highlighted in majority of the trials. It has reduced anywhere from 30 to 35% reduction in hospitalization for heart failure and all-cause hospitalization, and there is cardiovascular death. Different studies have quoted cardiovascular death to be reduced from 2 to 18%, and totally definitely reduces. If a drug can produce all these things, why not we use it in the management of cardiac failure? SGLT2 inhibitors have been shown to improve cardiovascular risk, as we have already seen. There is weight loss, systolic and diastolic is slightly reduced. And in CVOTs, SGLT2 inhibitors have demonstrated multiple cardiovascular benefits. And what are the cardiovascular benefits? As I told you, in EMPERAG outcome, there is a 35% reduction in the heart failure hospitalization. In the CANVAS, again, there is a 33% reduction, and in declaratomy, there is a 27% reduction. Cardiovascular death, even though minimal in declaratomy, you can see this sizable reduction in cardiovascular death in the other programs, and 3-point MACE is definitely reduced in all the trials. And in EMPERAG outcome, the effect of empagliflozin on heart failure hospitalization was consistent in patients with and without heart failure. Suppose the patient has had a no heart failure, it is still useful from the median line. And if he has had a heart failure also, it is still useful. So even if the patient has been included with a high risk of diabetes, high-risk diabetic patients, it definitely prevents the onset or delays the onset of cardiac failure. And whatever be the HbA1c, number one, within 12 weeks' time, there is a reduction in HbA1c, and whatever be the level of HbA1c, there is a reduction in cardiac outcomes. Canagliflozin, again another glyphosine in the credence, has retarded the progression of the end-stage renal disease to the end stage by 30%, cardiovascular death or hospitalization for heart failure for 31%, 3-point MACE by 20%, and heart failure hospitalization by a phenomenal 39%. And when you look at the DAPA-HF trial, worsening of heart failure or death is reduced by 26%, heart failure cardiovascular death by 25%, and composite kidney outcome by another 29%, and all-cause mortality by 17%. So the adverse events were very similar between dapagliflozin and placebo. And in the DAPA-HF trial, the effect of dapagliflozin on cardiovascular and heart failure outcomes was generally consistent between patients with or without diabetes at baseline. So you can give it to patients without diabetes also, but if they have cardiac failure, that is why this molecule has become the drug of choice among cardiologists today. And suppose the patient has been having the other 4 pillars of treatment for cardiac failure. He is taking ARNI or ACE inhibitor or ARB, beta blocker, MRA, and still the patient can benefit in all the segments. So even if you are adding on this drug to persons who are taking all the other drugs, it is still a very useful addition. Several SGLT2 inhibitor mechanisms may have beneficial effects on heart failure. When the drug was introduced, people thought it is causing improvement because of its diuretic effect. Later they had proven that it is not due to a regular diuretic effect, but due to a selective diuretic effect. We will come to it now. It causes natriuresis. It increases natriuresis because of proximal convoluted tube inhibition of SGLT2, and reduced preload and afterload, reduction in interstitial edema, and improved kidney function and cardiorenal physiology. How does it do? It does it through an sodium hydrogen exchanger dependent pathways. It inhibits the sodium hydrogen exchanger pathway, and therefore the renal sodium mechanism and the microvascular and macrovascular complications are definitely reduced, and because of this the progression to heart failure is also reduced. So one of the main mechanisms has been attributed to the sodium hydrogen exchanger independent, which is sodium hydrogen exchanger 1 in the heart and vasculature, and sodium hydrogen exchanger 3 in the kidney. SGL2 mediated blockage of sodium hydrogen exchanger, and reduction in intracellular sodium load, and restoration of mitochondrial function, and reduction in glomerular hyperfiltration and intraglomerular pressure. And as I told you, how does it differentially affect the volume overload? It reduces the SGLT2 inhibitors. If you look at this particular thing, they reduce the sodium, they reduce the interstitial volume, but the intravascular volume is maintained, which is responsible for having a patient with cardiac failure at least an acceptable BP. Whereas when you give a loop diuretics only on a chronic basis, the intravascular volume falls down. So what is important is relieve signs and symptoms of interstitial congestion, provide some relief of elevated cardiac filling pressure, prevents harmful effects of excessive blood volume depletion, including neurohormonal activation. Our patients will say, complain very often of severe postural hypotension. And this is how it affects cumulative urine output and fluid balance in patients with acute heart failure. You can see that there is a great reduction compared to the placebo in the volume. And what is unique about the diuretic effect? Selectively reduces the interstitial volume with minimal change in blood volume, no counter-regulatory stimulation. Suppose the blood volume is reduced, there will be counter-regulatory stimulation of tachycardia and ROS coming into play. No hypokalemia, improved renal function, reduction of uric acid levels, no hyperglycemic effect. So all these things are very, very important when you give a drug to cardiac failure patients. And we have already seen how it improves. Cardiac preload is reduced by natriuresis and increased diuresis, and LV diastolic function and the LV mass is reduced. and therefore there is metabolic efficiency, oxygen supply is improved, fibrosis is lessened, epicardial fat is lessened. There were several papers which had shown the reduction in LV muscle mass, especially the epicardial fat, and therefore there is improvement in the cardiac function. And cardiac afterload is reduced because of endothelial function, arterial wall stiffness, and vascular resistance is improved. See, these two were the main principles that were used before we started getting ACE inhibitors and ARBs. We used to have cardiac preload reduction as a method of treatment of cardiac failure and cardiac afterload reduction. And that is how you had the combination of isosorbide dinitrate with hydralazine. So people who cannot afford very costly drugs, we used to give digoxin diuretics and then a combination of hydralazine with sodium isosorbide dinitrate. The reason is isosorbide dinitrate will reduce the preload by capillary dilatation, and afterload is reduced by hydralazine. Even today, many of us are using that in poor patients who can't afford. EMPA heart study showed a meaningful reduction in LV mass index, that is the muscle mass, from baseline with empagliflozin versus placebo, and this is one of the major mechanisms by which it causes an improvement in the cardiac status. This all of you should be familiar as diabetologists, and this is suppose a person's life is 72 years, it gets reduced when he gets diabetes by 6 years, and if he has had a coronary artery disease also in the form of an MI, it is reduced by another 12 years. And when we use drugs like this for cardiac failure, what we had found is reduction in relative risk mortality versus placebo. When we used ACE inhibitors like ramipril, the cardiac failure mortality is reduced by 16%. ARBs reduced the CHARM alternative trial by 23%. Beta blockers, the metoprolol, bisoprolol, and cardiolol reduced by a phenomenal 32 to 34%, and the mineralocorticoid receptor antagonists reduced by 30%. Now, if you come to the glyphosins, SGLT2 inhibitors, you get a 3-point reduction of 14%, cardiovascular death of reduction of 38%, hospitalization for heart failure by a phenomenal 35%. So why not we add on all these things and give a better lifestyle to the patients with cardiac failure and a prolongation of life? Now, number needed to treat, as long as the number needed to treat is less, that means the drug is very, very effective. When simvastatin is given for 5.4 years, you require 30 patients to reduce the number needed to treat is 30. And when it comes to ramipril for 5 years, the number needed to treat is 56 years. But when it comes to empagliflozin for 3 years itself, if you treat only 39 patients, you are able to reduce the mortality. So what is important is, in addition to the other drugs, you can use an SGLT2 inhibitors. So when we started treating recently from 2018, we started saying there are 5 pillars for the treatment of cardiac failure. ACE inhibitors are ARB. If the patient is ACE inhibitor ARB naive, we used to go to neprilysin inhibitor straight away, that is ARNI, and then beta blocker, MRA, and SGLT2 inhibitor. Time and again, people used to ask it in most of the meetings, so which one to start, which one to go, there are complications, patients come with hypotension, how do we go about? One of these things that we should understand is there are 5 pathways. As I had told you in the beginning itself, the sympathetic nervous system pathway, norepinephrine, the RAS pathway, angiotensin 2, the MRA, that is aldosterone, again RAS pathway, aldosterone, and neprilysin and SGLT2 inhibition. So 5 pathways, 4 drugs. We all know SGLT2, MRA, beta blockers, and ARNI. And 3 others are in patients in whom you have used all the 4 pillars of treatment of cardiac failure, we can still reduce the heart rate, because reduction of heart rate in a cardiac failure patient has been proved in SHIFT trial to improve their quality and quantity of life. So ivabradine, suppose we are able to use a maximum dose of beta blocker, still we are not able to control the heart rate, or we are not able to use the beta blocker because of low BP, we can straight away add or use ivabradine without any cardiac effect. It can reduce the heart rate and prolong the life of the patient. This I have already talked to you about afterload reduction and preload reduction, hydralazine nitrate combination, and Versuguat is a recent drug which acts on the mitochondrial level to improve the contraction of the heart muscle, and we are getting it. It is like semaglutide in diabetology, Versuguat in cardiology, very costly, but when all the other 4 pillars fail, we can still start using that and try to give them some relief. Now, which one to start first? As I have told you, a lot of people ask us questions. Sir, a patient comes with hypotension. How can we use an ACE inhibitor or ARNI? After you stabilize the drug, you can start using it. So what happens is Milton Packer and who is it? McMurray. Both of them said, why not we start with SGLT2 and beta blockers once the patient is unloaded. You cannot give a volume-loaded patient beta blocker. Once the patient is unloaded in the ICU, you can start on beta blocker and SGLT2 inhibitor, because cardiac failure, you are going to give a lot of diuretics. You may have metabolic parameters getting altered like high potassium, low potassium. So safest is to start with these two and then slowly add on ARNI, and then if still it is not controlled, mineralocorticoid receptor antagonist. Only thing is, when you give these two drugs, you should be careful enough to monitor their potassium very frequently, as early as 2 weeks. You should do this. So simultaneous initiation of beta blocker and SGLT2, then addition of ARNI within 1 to 2 weeks of step 1, and addition of MRA within 1 to 2 weeks of step. You add this only if you do not find improvement with these 2 steps. And as I told you, McMurray and Milton Packer in circulation had talked about this step. And old sequencing was, we used to start with ARNI because that's what we had, and we had proven that it has reduced hospitalization for heart failure. And then we used to add beta blocker, then MRA, then ARNI. Now SGLT2. Now, having been treating patients over the years and having had a lot of biochemical imbalance and hypotension, one of the best methods that has been suggested by them in 2020 circulation is, why not we try like this, safer for the patient and for the cardiologist who treats. Now, estimated clinical benefit in heart failure with reduced ejection fraction is greatest for which combination? Is it for ACE inhibitor, beta blocker or MRA, or for this? You can see very well in this one, ARNI, beta blocker, MRA and SGLT2 gets the greatest benefit. That means hospitalization for heart failure is reduced to the maximum level. Thank you.